Good evening, Dr. Adel. Good evening, everybody. Good evening to all the attendees. First of all, I'd like to thank everybody for joining this evening on a weekday, and everybody has showed up on time as well. That's much appreciated. Today we have a really interesting talk where we're going to be relaying sort of the similar sort of messages we've been delivering in the clinic with regards to how we can utilize SGLT2s, particularly for SIGA, to treat diabetes beyond the A1C level, and how we are shifting towards now looking at how we can target cardiorenal risks, and how this has been the general now move forward and has taken precedence over options that can only provide A1C benefits. And in this scenario, we're going to be taking it forward in the format of a patient discussion, have sort of a makeshift real-life practical scenario. Today's discussion is going to be presented by Dr. Adel. Dr. Adel is a consultant endocrinologist at the NMC Royal Hospital in Sharjah. He has extensive experience, not just treating diabetes, but also working with Farxiga. Extremely well-versed with the drug and its results, as well as in the treatment of the diabetic patients in general. At the end of the discussion as well, we can have a short Q&A panel discussion for anybody that has questions. Can definitely feel free to come forward, pose questions in the chat, or you can unmute and ask Dr. Adel yourself. Now, with that being said, we can begin the presentation here. And without further ado, Dr. Adel, please, the floor is all yours.
Thank you, Dr. Amr Hatem, for introduction, and thank you for our colleague to attend today to share our experience together. And thank you for AstraZeneca to sponsor this meeting of today. And let's go for our title of today. What is the importance of early initiation of SGLT2 inhibitors when become as monotherapy or combined with metformin from the view of type 2 diabetes management, which is management of cardiometabolic risk reduction. Let's go for our melody of today and the harmony of systems in diabetes management, which we can call this disease. Diabetes is not only one organ disease, it is multi-organ disease and affecting other organs, and there is like pathogenesis in many organs due to diabetes. So how we can make a harmony and diatone between pancreas, kidney, and the heart. Diabetes is defined not only endocrinology disease. Diabetes, it's also cardiology disease. It's also nephrology disease. These three specialties controlling diabetic patient. Diabetes before was only hyperglycemia, but the recent view of pathogenesis of diabetes, it is multi-system disease, especially endocrine pancreatic disease, cardio disease, and nephro disease. So let's go for the factors increasing the cardiometabolic risk in diabetic patient. Diabetes is defined as multi-system disease. Diabetes is defined complex of cardiometabolic disorders, and the major cardiometabolic factor and the impact is diabetes. Why diabetes prevalence and incidence worldwide increase? Why diabetes expected in the International Diabetes Federation Atlas in 2045, the number of diabetic will be double than nowadays. Nowadays, it's about 300 million up to 400 million, expected to be near than 700 million worldwide people affected by diabetes. Due to many cardiometabolic factors and cardiometabolic risk. Number one risk is overweight and obesity, which represent about 80 to 85% of causes of type 2 diabetes. And hence, diabetes management and diabetes prevalence, prevention and prevent the prevalence and incidence of diabetes coming from weight reduction and weight control. Other factors, hidden factor like insulin resistance, which can be high risk to be turned to type 2 diabetes, physical inactivity in the Gulf area and MENA area, which is modern life and using cars and not using legs at all and no exercise because of the hot weather, although it is not a reason now because there is many clubs and gym and sport availability with good condition of the air, and it can be available in all the country. So smoking and physical inactivity and sedentary lifestyle in the MENA region, it is one of the factors. Hypertension, it's multi-system disease, can affecting to have the risk of diabetes. Inflammation and hypercoagulation, genetic factors and family history and dyslipidemia all contribute to increase the prevalence and incidence of global diabetes. And whence their diabetes increase because they are interlinked diseases, cardiovascular diseases increase, and renal diseases increase. So what is the ideal management of type 2 diabetes? In the past, diabetes is only hyperglycemia, so reduce blood sugar, your mission is completed, and this is after detailed studies and more deep in the pathogenesis, it not control the complication of diabetes, even so we have controlled hemoglobin A1C. So diabetes is not only hemoglobin A1C. Control of diabetes is multifactorial pathogenesis prevention to prevent the future of our patient. Our mission is not only today control, our mission is tomorrow control. How we can see our patient after 5 years or 10 years. So the 4 bases of ideal type 2 diabetes management from the view of cardiometabolic risk reduction is hemoglobin A1C reduction, weight reduction, dyslipidemia management and LDL reduction, and blood pressure control to be less than 130/80. Mr. Hashim, one example of our case presentation of today. Mr. Hashim, it is like imagination about very common patient coming to all our clinic today. Which clinic Mr. Hashim visit? He visit GB clinic, family medicine, endocrinology, cardiology, nephrology, internal medicine. Mr. Hashim is a common patient. By this imagination, but with different names. We have this profile in our clinic, not only endocrinology clinic. So when we try to apply the diatone between the 3 system, multi-system disease of pancreas, protection and the preserving of the remaining of beta cells, and prevent the cardiovascular disease and prevent chronic kidney disease and diabetic kidney disease, we can deal with Mr. Hashim for today and tomorrow, not only for today, from the view of cardiometabolic risk reduction. In this example, Mr. Hashim, his hemoglobin A1C 7.6. Do you believe Mr. Hashim is protected enough? It's not only hemoglobin A1C. I am not here speaking about 7.6 when the ideal control for middle-aged people to be better than to be less than 6.5. No, this is not the mission for us. From the recent view, we have a many defect in the future of Mr. Hashim. Let's go step by step. How we can treat Mr. Hashim today and how our treatment of today affect his tomorrow. Tomorrow here for his future, today here for his current time. So, how you treat Mr. Hashim today affect his tomorrow? If you can imagine that 68% of patients with type 2 diabetes, they develop cardiac and remote within 5 years from diagnosis. So Mr. Hashim is only today diabetic, but after 5 years, this is tomorrow for Mr. Hashim, he may be one of the 68% of cardiac patients. Mr. Hashim need from us not only to control his sugar, need from us looking for after 5 years to not be one of the 68% of diabetic people which turn to have cardiac disease. Also, 40% of type 2 diabetes patients, they have chronic kidney disease and chronic renal failure. And the sequence of chronic kidney disease stages up to end stage of renal disease, and the most common cause for this is diabetes. So we need to protect Mr. Hashim from sugar and from cardiovascular disease and from kidney disease. This is for the future of Mr. Hashim. So also up to 50% of diabetic patients, they develop heart failure. Only 1 in 2 patients with heart failure will survive for 5 years or more. So we not only speak about Mr. Hashim controlling of sugar, we speak about life expectancy for Mr. Hashim as well, and for his family, and for his community, and for his productivity, and for our mission as we are the saver for Mr. Hashim today and future. The guidelines recommend cardiovascular and renal risk reduction in management of all type 2 diabetes patients. The American guideline, the European guideline, and the UK guideline, and Australian and the Canadian, and all. We should include in our medication what can help in protection of heart and kidney. And if we can see the recommendation, and this is very summary about not detailed the recommendation. I don't want to make it very long. I will cut the story short to give the highlights that the all guidelines, they recommend SGLT2 inhibitors and GLP-1 receptor agonist as a protection for heart and kidney, and control the main cause of type 2 diabetes, which is the weight. It is only endocrinology guideline? No, I told you, diabetes now is not belonging to endocrinology alone. We will find that also in the cardiology guideline. We will find it also in the nephrology guideline. So multi-specialty guidelines and the multi-region guidelines all recommend to protect our patient for future, for heart and for kidney, and for preserve the remaining of beta cell or pancreas. So the summary of American Diabetes Association focus on patient-centered glycemic management to avoid the many issues that regular assessment for our patient and the modification of treatment and initiate agent for heart and kidney protection, it is recommended by the guideline. Metformin and lifestyle management remain #1 of the recommendation, and especially in newly diagnosed type 2 diabetes, and we should start to consider combination when hemoglobin A1C is about 2% above the target of the treatment. And what is the target of the treatment of the middle age? It is different from age category to other age category. If we have young with type 2 diabetes, like less than 20 years, we need them near normal. So less than 60 is preferred. Middle age from 25 up to 60, we need this target of people to be less than 6.5. And the elderly patient, more than 65 and above, we need them just to control at least between 7 and 8 because of the risk of hypoglycemia in elderly can cause death for them. So in all the recommendation in 2020, 2021, 2022, 2023, all in American diabetes and European, when we see is in the summary, they now implanted and started to give it as a structure of cardiovascular risk reduction as mandatory of treating of our patient, especially the high risk patient, obese patient, hypertensive patient, dyslipidemia patient, and high family history risk patient. So it is different, but it is very structured now to recommend for weight reduction, LDL reduction, blood pressure control, and hemoglobin A1C control, and add agent to help to protect kidney and heart, especially if can available of SGLT2 inhibitor and GLP-1. So here we have a recommendation after metformin and lifestyle. What is the best to our patient? I told the guideline now start to not give us the choices like before. Before the old guideline is like we are in the restaurant. After metformin, doctor is the decision maker to choose the second agent added to metformin. He can choose bioglitazone, he can choose sulfonylurea, he can choose SGLT2, he can choose DPP4, he can choose insulin. No any recommendation, only just hemoglobin A1C control. So in the recent guideline, there is a ladder and algorithm of initiating the second agent, especially in high-risk patients. And diabetes itself, it's a high-risk patient. As I mentioned, 68% of diabetics, they are liable to cardiovascular disease. So they are, only to have a diabetes, you are a high-risk patient. If you added hypertension and dyslipidemia with diabetes, this patient become very high risk. If you add obesity to diabetic patient, type 2 diabetes, we find them about 80 to 85% of our diabetic patients, this is high risk patient. So what is the best? To start after metformin with DPP4 or to start with SGLT2 inhibitor or GLP-1 or bioglitazone or sulfonylurea. Sulfonylurea now the worst medicine according to all guidelines. More weight gain, more cardiovascular risk, more LDL elevation, more pancreatic exhaustion squeezing pancreas, and more risk of hypoglycemia. But what is the second agent in the guideline? GLP-1 is second agent after metformin, but SGLT2 inhibitors, it's also in the same category like GLP-1. Some people, GLP-1 become costly, not tolerable due to the side effect, and it is not applicable in some patients don't like injection, but SGLT2 inhibitor don't have this side effect and very simple and not costly and no severe side effect and can be tolerated easily. So have a good rule than GLP-1 in mostly of our patients, especially if there is cost, impact, or other contraindication of GLP-1. So initiation of SGLT2 inhibitors and GLP-1 receptor agonist in patients with indicator of high risk or established cardiovascular disease, heart failure, or chronic kidney disease have many benefits and have many protection for the future of our patient, and gave significant statistics of reduction in cardiovascular event and improvement of the kidney disease or prevention of kidney disease. Patient without indicator of high risk or established cardiovascular disease or heart failure or chronic kidney disease need to minimize hypoglycemia. So it is not only for cardiovascular disease. If I am fearing from hypoglycemia, so what is the three medicine have good impact in reduction of hypoglycemia or low risk of hypoglycemia after metformin? SGLT2 inhibitors and GLP-1 and pioglitazone. But why we not include pioglitazone in the priority? Because the risk of weight gain. So almost 80 to 85% of diabetic people, they have overweight. And to add more weight, you are not taking care about risk reduction of the obesity and diabetes, and can make the cycle of diabetes in the future not good well controlled and the side effect of obesity. So what is the, after failure of all of this, what is the high risk medication of hypoglycemia? We can insulin and sulfonylurea, they are the high risk of hypoglycemic medication, but there is a new generation of sulfonylurea and insulin. Once indicated, after failure of all of this, they have little low risk of hypoglycemia, like ultra long basal insulin analog like Tresiba and Toujeo, and in sulfonylurea, the third generation or fourth generation of sulfonylurea, like Glimepiride and gliclazide modified release, which are in the market. But as much as we can avoid this medicine because of the side effect of weight gain, pancreatic exhaustion, and many other side effects according to the guideline. So, is weight reduction help to reduce the cardiovascular risk? Yes, for sure. Is LDL reduction can contribute to reduce the cardiovascular risk? Yes, for sure. Is hemoglobin A1C reduction can help in reduce the cardiovascular risk? Yes, for sure. Is blood pressure less than 130/80 in diabetic patient can reduce the risk of cardiovascular disease and kidney disease as well? Yes, for sure. So our checklist is not only hemoglobin A1C. It's hemoglobin A1C, kidney protection, heart protection, and LDL reduction, and blood pressure reduction, and as well hemoglobin A1C reduction. So patient without indicator of high risk or established cardiovascular disease need to promote weight loss and minimize weight gain, as I mentioned before. So even though I don't have a high risk of cardiovascular disease, we can consider SGLT2 inhibitor and GLP-1 for obese patient, because obesity, even this is not have calculated risk of heart disease or cardiovascular disease, it is very high risk also to affect the heart, as obesity is a disease, have many pathogenesis and can affect the heart. So in the summary of American Association of Clinical Endocrinology and algorithm for glycemic management, glycemic target for mostly middle age should be less than 6.5, and in patient elderly we can make it little high. Dual therapy should be considered if hemoglobin A1C increase by 1.5 to 2%, A1C target and the choice of therapy must be individualized based on many factors and individual circumstances and risk assessment. Glycemic control target including fixing the fasting plasma glucose and postprandial, not only fasting or not only postprandial, and this need from patients some self-monitoring of blood glucose to control and fix both fasting and postprandial. A choice of therapy reflect patient of established cardiovascular disease, heart failure, and renal status. Minimize weight gain and risk of hypoglycemia as a priority. Therapies with complementary mechanism of action for optimum glycemic control as an add-on therapy to metformin. So when we use SGLT2 inhibitor beside metformin, there is two mechanisms of action and two complementary synergism between this mechanism of action and not affecting the cardiovascular risk, but reduce the cardiovascular risk. And using metformin and GLP-1, this is also two complementary mechanisms of action, and hence going for, it is not only glycemic control, it is beyond the glycemic control. It is cardiac protection, it is nephroprotection, it is future of our patient and life expectancy and survival for our patient. So the recommendation after lifestyle modification and after metformin, independent of glycemic control, it is not only glycemic control. If patient high risk or have kidney disease or any high risk, we can consider to add SGLT2 inhibitor and GLP-1 by the name from the guideline. So monotherapy for people hemoglobin A1C less than 7.5. And there is a question here. We can give SGLT2 inhibitor or GLP-1 receptor agonist as monotherapy. Yes, in some cases, if metformin contraindicated, if the patient have allergy from metformin, if the patient have peptic ulcer disease, if the patient cannot tolerate the symptoms of side effect of metformin, so we can consider GLP-1 or SGLT2 inhibitors in this contraindication to be as monotherapy as well, and this is also by the guideline. So the summary of the guideline of the American and European give us the primary prevention of cardiovascular disease and the kidney disease. Metformin should be initiated as first-line pharmacological therapy along with lifestyle modification if metformin not contraindicated. I'm adding this. This is also in the guideline. And patient not have good goal or have additional cardiovascular risk or kidney risk, kidney disease risk, despite treatment with metformin and lifestyle, we can consider early initiation as soon as possible with SGLT2 inhibitor and GLP-1 or both to improve according to the glycemic target we need to reduce the cardiovascular risk and the kidney risk as well. So again here, I am not going too much for this, that here how we can go from this is another guideline, the American Association of American Heart Association and the American Cardiology. So this is not the endocrinology guideline. Now in the cardiology guideline as well, they start to speak about treatment of diabetes from the view of cardioprotection, from the view of reduce the cardiovascular disease risk, They now mandate the doctor to give the agent to prevent the people, and primary prevention for people with high risk of cardiovascular disease of type 2 diabetes. This we need to prevent the future for high risk people from cardiac disease. So what is the mechanism of action of SGLT2 inhibitor? It is very good, like independent of pancreatic mechanism. It's working away from the pancreas. It is block the SGLT2 enzyme in the proximal tubules of the kidney, which is responsible about 90% of sugar reabsorption from recycling from the kidney waste. And when we block this, so we remove the excess sugar in the urine waste. Is it good for us? Yes, it will help to rest the pancreas, to not more squeezing for insulin. It can make little load for pancreas, little mission for pancreas to produce insulin. What else? It is also remove some salt waste, some fat waste. That's why it help in weight reduction and help in blood pressure reduction and help in sugar reduction. And from all of this, help to cardioprotection and nephroprotection. So today for Mr. Hashim, the way you lower his hemoglobin A1C and what you choose for Mr. Hashim today, it can matter. He's Mr. Hashim in the future. Mr. Hashim today is only diabetic, but he carries a risk of 68% to have heart disease, and 50% to have heart failure, and 40% to have kidney disease. So we not only look for Mr. Hashim of today, our honest practice to look for Mr. Hashim future, for his family, for his survival, for his suffering. For today, Mr. Hashim and the patient like Mr. Hashim with different name, when we gave SGLT2 inhibitors, dapagliflozin, empagliflozin, today we highlight the role of dapagliflozin by the brand name of Forxiga and the combination with metformin, Zegdo, it can help to lower the hemoglobin A1C with additional beyond glycemic control of lowering blood pressure and weight and lowering the cardiovascular risk. So Mr. Hashim today, only diabetic, but protected for the future. Here, dapagliflozin, Forxiga, significant reduce hemoglobin A1C when used as essential therapy or add-on in type 2 diabetes. It can be used essential, initial, or monotherapy, yes, if contraindication for metformin or for patient with heart risk, heart failure, or whatever, we can overlap metformin and give agent if his hemoglobin A1C 7 and patient is heart disease or starting to have kidney disease or very obese. We can bypass metformin in some patient to give another option, carry a lot of protection of the future for our patient. It is effective when giving as monotherapy or when added in metformin or other medication in type 2 diabetes match. And dapagliflozin, when added to metformin, they have very good demonstration of significant reduction in hemoglobin A1C versus if we compare metformin DPP4 to metformin SGLT2 inhibitor, more reduction of hemoglobin A1C with many other benefits. In my choice, in my clinic patient, if I have patient come to me controlled with metformin and DPP4, I change the medicine to metformin SGLT2 inhibitor if this patient have risk. So I'm not looking for hemoglobin A1C alone. If this patient obese, what is the benefit of DPP4 for this patient? If this patient have high risk of cardiovascular disease, dyslipidemia, blood pressure, and obesity, and or have any heart disease, what is the benefit of DPP-4 to this patient? Even his hemoglobin A1C was controlled. I'm changing according to the risk, not only for target of hemoglobin A1C. I can give my patient medicine with one option and one function and give control of blood sugar, and I can give another agent, can control blood sugar and give me 4 function or 5 function: weight reduction, heart protection, kidney protection, LDL reduction, blood pressure reduction, and reduce the cardiovascular risk. So give 5 function or give 1 function. And cost-wise, it is similar DPP-4 to SGLT2 inhibitor for the cost. So Forxiga, when added to metformin, demonstrate greater weight loss. And here, weight loss in comparison to DPP-4. So I need for obese patient, 80 to 85% of type 2 diabetic patient, weight reduction, it become now mandatory in the guideline for overweight diabetic patient. To give neutral weight agent or to give weight reduction agent for obese patient type 2 diabetes. And what is the benefit of reduction of the weight in type 2 diabetes? It reduces the cardiovascular risk. It improves glycemic control. It improves the dyslipidemia, LDL reduction. It improves blood pressure reduction. This all from weight reduction benefit if you use agent help patient overweight to reduce weight. So also Forxiga demonstrate, or dapagliflozin by the scientific name, additional benefit of weight reduction over a number of combination with evidence for use across broad range of treatment. Here, monotherapy, there is weight reduction. Add to metformin, there is weight reduction. Even add to sulfonylurea, there is weight reduction. But we are here not safe about hypoglycemia. We are not safe about the little weight reduction when added to sulfonylurea. And if we see the risk of pancreatic exhaustion. So if we use 2 benefit medication, 2 weight reduction medication, or at least 1 weight reduction and 1 weight neutral medication, it can help our patient. When added to all, we will find that there is more important comparison of weight reduction in the arm of dapagliflozin over other medication except GLP-1, because the GLP-1 reduction is more with the GLP-1 agent have more impact in weight reduction than dapagliflozin. What about for people moderate obesity or high obesity or comorbid obesity or class 3 obesity or class 2? If we add 2 agents for weight reduction like SGLT2 inhibitors and GLP-1, more benefit. If control of sugar by reduce more weight for very obese people, it is more benefit and more cardiovascular risk reduction for our patient as well. So also dapagliflozin demonstrates significant systolic blood pressure reduction when added to anti-diabetic therapy with comparison of using other anti-hypertensive. So if we add dapagliflozin to anti-hypertensive medication treatment for diabetic patient, instead of titrate the antihypertensive and after some time we need to increase the dose, dapagliflozin can solve the current dose of antihypertensive without titrating up of antihypertensive medication with the studies. Forxiga also, when added to metformin, demonstrate significant and sustained systolic blood pressure reduction over 4 years. Not only it is transient effect, it is tested in 4 years. For tomorrow, for patient like Mr. Hashim, Mr. Ahmed, Mr. Hashim, Mr. any name, Arabic or Indian or any human, diabetic, we need to keep his future. This is our loyalty for our patient. This is our mandatory mission for our patient, to look for like people like Mr. Hashim coming to our clinics with different specialties, how we can plan for his future. Dapagliflozin go and SGLT2 inhibitors as a class also, although there is difference between molecule and the molecule, and the best is dapagliflozin and empagliflozin by all the guidelines. So dapagliflozin go beyond glycemic control to reduce the cardiorenal risk versus placebo. So our diatone and our harmony and our musical management for type 2 diabetes, it is cardiorenal metabolic risk reduction for our patient. This is beyond glycemic control. This is to protect the pancreas and kidney and heart, and the interlink between these three organs can give us the protection, more life expectancy for our patient, and more cardiovascular risk reduction. And you can be satisfied that you are doing your mission very professional, and you're looking for your patient not for today, for tomorrow. And thank you for allow me to speak about this eminent molecule in type 2 diabetes management. And the floor now again for any question, I will be happy to answer it.
Thank you, Dr. Adel. That was excellent. This was a fantastic overview of the guidelines. Had extremely well broken down, well thought out, easy to follow, but yet at the same time also a very comprehensive review of the guidelines and where Farxiga sits in between the different options available today, and how we are moving forward towards now thinking of A1C, or thinking of targeting just A1C as sort of an afterthought, and there is becoming now more important issues at hand. Now, yes, just like as Dr. Adel just said, the floor is open now for anybody that has any questions. Please feel free to either unmute yourself and speak the question directly to Dr. Adel, or you can also drop the question in the chat.
So until if there is question or not, let's speak about our patient profile in the clinic. We have how many patients diabetic and have dyslipidemia? We have how many patients in our clinic diabetic and have hypertension? How many patients diabetic and overweight? How many patients suffering from medication with side effect, medication with weight gain, medication with side effect of hypoglycemia, medication with GIT symptoms? So to write a medication for your patient, it is like individualization according to case. I'll give you a funny story about one of my patients. His hemoglobin A1C about 7.5. It's like Mr. Hashim. He is taking metformin 1,000 twice daily, and he is overweight. And he come to me, tell, doctor, I'm taking this medicine for about 2 years. I'm telling, fine. So what you find in these 2 years? Doctor, I have problem in my stomach. I have problem in my digestion. I am not happy. Even, no, I am not feeling problem from sugar. I'm not feeling from the symptoms of high blood sugar, but I'm feeling not comfortable. When I discuss with him, if you have diagnosed by any like problem in your GIT, yes, doctor, I have like problem with acidity. I have problem with, before I have a gastritis, before I have maybe reflux, and this and this and this. I'm really, I'm shocked. This patient follow up with his doctor for 2 years, and he not asking about what is bothering him, and he cannot pick up between the line that this patient have this reflux and gastritis. He can turn it to peptic ulcer disease or bleeding or perforation because of the side effect of metformin. I'm not looking here for the control of hemoglobin A1C, although it is mandatory, but I give you example. This patient, by the way, I gave him SGLT2 inhibitors and DPP4. One tablet from this, one tablet from this. And I schedule with him appointment after 1 month. When this patient come after 1 month, he said to me like a poem. He started to give me like, thank you, doctor. Thank you, doctor. Thanks for sugar? No. All my GIT symptoms is resolved. I'm now not using the medicine for my GIT. My digestion is very good. My body, I'm feeling very fit. I'm very happy. First time I'm eating like normal people. Always when I eat anything, small thing, reflux and acidity, I'm fearing from eat. Now I'm happy to eat, regardless of my sugar. And when I see also the hemoglobin A1C is not after 1 month, but later on in the follow-up, he is much improving. But the problem here is not patient. My patient, it's the individualization of the medicine. Not take the guideline like metformin is #1 medicine. Okay, if the patient have problem with the side effect of metformin, it will not be #1. We can write #4. I have patient, I treat some patient with pioglitazone starting medicine. Pioglitazone, doctor, he tell you not use it because of weight gain. I have one patient, type 2 diabetes. His weight is 40 and his age is 50 and he is very thin and very underweight. His doctor gave metformin, become more worse. His weight becoming, he's 40 kg. You can consider it is very thin. When take metformin, he's become more thin and he throw all the medicine. Other doctor, I will give you best medicine in the world, SGLT2 inhibitor. He's reducing weight again. He throws this medicine. Other is when he come to me, I gave I need anything make me little fatty. I need me to have some gaining weight. So I use pioglitazone for the side effect of weight gain, because his psychology is destroyed because he become very thin. So art of right medicine, it is your patient. Your patient is your playground. If the patient not have the risk and this and this and this, why I'm choosing from the guideline what is the best low risk of hypoglycemia? For sure, if this patient, I can prescribe for him maybe DPP4, no problem. But this patient, he is telling me, I need to increase my weight by any means. I hate metformin. I hate SGLT2. I hate anything. Give me something to help of my weight. This is my concern. Addressing the patient concern is one of your role as a doctor, but not to harm the patient. Not address the patient concern to give something contraindicated. Pioglitazone is one of the medicine in the guideline. It is not contraindicated. Not to give him, if his sugar is very little, to give him sulfonylurea also is making weight gain. But why not give it? Because risk of hypoglycemia, his diabetes is very little. He can destroy the beta cell and exhaust the beta cell, but pioglitazone don't have this all. If the patient don't have bladder cancer or not heart failure or not overweight, it is best option in some patients. So to address a medication for our patient, it is different and individualized according to risk and complaint and address his concern if it is not against the protection of the patient. This is only I discuss something in my mind. And sorry if I make you late or something. It appears that no question. So
no, I think there is a question here, Dr. Adler. But yes, this is a very interesting point, of course, about tailoring The medication, yes,
There is which
definitely.
okay,
Yeah,
what
so
is the
there is a question here. I'll read it out for you. It's coming from Dr. Razuna, and her question is: due to increased glucose excretion through the kidney, can this have any negative impact on nephropathy, despite having an overall renal protective effect?
This also good question, because any medicine have his good and his bad. But according to EGFR and according of the stage of kidney disease, SGLT2 inhibitor can be given up to GFR 45 blue, yani up for 45, and some evidence now about above 30 GFR. So for people GFR less than 30, there is no safety to give. It will worsen the kidney disease. It will affect the kidney disease. But more than 30 in some molecule like empagliflozin and I think also dapagliflozin, and all of the SGLT2 inhibitors can be given above 45. All studies about the kidney impact is to increase and improve the kidney efficiency. But in high-risk people for dehydration, like elderly patients, they can go for dehydration because of polyuria, and they not tolerate to drink a lot of water. It should be used with cautious according to risk classification and the close monitoring of the patient, because dehydration from SGLT2 inhibitors can be worse the kidney function. So we always instruct our patient using SGLT2 inhibitors to drink plenty of fluids and water.
Perfect, doctor. Yes, definitely the Farxiga can be used, yes, with the GFR, initiated at the low GFR range, 30. There's a trial that shows even lower, like at 25 is what can be used, and that's the lowest it can be initiated at. And yeah, perfect. Appreciate the response there. I have a question actually that I get asked sometimes. I guess it's like a relatively common question, so sort of like a simple question. It's about regarding the safety with using Farxiga or the SGLT2s alongside insulin. What do you think about this?
With what?
With insulin.
Insulin?
Yes, like is it safe? The question is it safe to use alongside with insulin?
What is here to ask you more about, to give more details about the question to understand what is in your mind in this question related to each other, like what is the contraindication or what is the bad side effect of both medicine to each other?
Yes, in terms of safety, I guess, because let's say patient is like type 2, not type 1 diabetic, but they're taking insulin. But also taking Farxiga. In this case,
for me, it is best option. Why? Why? What insulin is doing is weight gain. Yes or no?
Right. Yes, correct.
Yes. Insulin is considered one of the weight gain medication or not?
Yes, it is.
Okay, and weight gain for diabetic patient is additional risk for them or not?
100%.
Okay, to overcome the side effect when is insulin is the first line of treatment for type 2 diabetes?
No.
When we initiate insulin, we are mandated after failure of oral medication because of glycemic control or not?
Yes.
Yes. When we mandated to introduce after oral medication, and we will have side effect because we are mandated of weight gain.
Yeah.
SGLT2 inhibitors here, it is and can reduce the side effect of weight gain.
Yes.
Besides, there is complementary mechanism of action. which can lead to down titrate of doses of insulin.
Mhm.
From here, we can reduce the risk of hypoglycemia as well.
Mm.
So here many
Yes.
benefits. Here many benefit to add SGLT2 inhibitor to insulin people.
Yes,
We
excellent.
we will reduce the dose of insulin
Mhm.
because SGLT2 inhibitor will help to reduce hemoglobin A1C.
Mm.
So we will use the minimum dose of insulin required instead of give high dose. We will reduce the weight or make the weight neutral effect of weight gain with weight reduction. It will make weight neutral effect for our patient, which is
Yep.
benefit instead of have weight gain.
Yes. Yeah. Excellent. This was an excellent breakdown of it. You see, having counteracting the side effects, helping with the A1C, and as well as reducing the load that you need to use for the insulin, the weight gain. Yes, that was an excellent overview. And yes, of course, just to clarify, it is safe based on the data as well to use alongside with insulin. Now, at this point, I believe we answered the questions here, and nobody else posted any more questions in the chat. So I believe we can conclude then the presentation from here. I want to thank you again, Dr. Adel, for the presentation.
Thank you for all my colleagues. I hope I won't. I was not boring by long discussion, and it's all coming for like mutual sharing of our practice together. And thank you for all, and thank you for this fruitful discussion.
Thank you. Thank you, Dr. Adel, and thanks for everyone attending as well. Thank you for all the attendees for attending. Yes, okay. Thank you. Have a great night, everybody. Take care.